And now I come to another close friend of mine, Dr. Mohammad Lazrak. Lazrak and me, we met first time in Karachi, Pakistan, and then we became friends. We have been exchanging notes, and he is a magician. Any problem with the instruments and with the technique, and if you are stuck anywhere, I always remember Lazrak, and he gives me guidance. And he has so many hundreds of videos on YouTube of how he has invented different procedures and different instruments so that the PCNL has made easy. He is past chairman, Department of Urology, Military Hospital in Morocco. He is pioneer and revival of endourology in Morocco. He has pioneered this technique. He has special expertise in endourology, PCNL, and with development of proper techniques, PCNL in the split leg modified lateral position, needle renal displacement technique, percutaneous endopyloplasty. So many techniques he has invented and named them. If you go on listening to him for more than 6 hours, even then it will not finish. He was invited to UCCon in Kochi, where he gave a lecture for 2 hours, and everybody was mesmerized to see his different innovations. He has been attributed development of many simulation models, glove model for puncture. Everything is on the YouTube. Endourological stone manipulation, TRP model with sheep kidney, nephron sparing model with a wheel kidney. He gives many tips and tricks and innovations. So everything is written here, and because of shortage of time, I straightway invite Professor Muhammad Lazrak to share with us some important techniques which we will require in our day-to-day life. I am stopping share of my slides. Muhammad Lazrak, please share
Lejrak
your
sir,
slides, sir, and come on.
thank you for accepting the
Welcome.
invitation, Professor Lejrak. Please.
Yes, thank you, dear chairman, dear colleagues and friends. So it is pleasure for me to be with you in this international webinar, and greetings from Morocco. So I will try to share with you some cheap innovations that we have developed with the help of my friends. So I am doing full-time voluntary work since 2011, helping small groups of urologists in Morocco, and also doing a lot of workshops in Africa and lots of presentations. So all the ideas that you will see are teamwork. So they are ideas gathered by interacting and brainstorming with friends. So why are we looking for cheap solutions? You know, in developed countries, they had the availability of equipment. However, some people don't have this. So things are not available. Why? Because there is a lack of money, there is a poor organization, but mostly there is an administrative hassle and slow motion. So how do we do to have a cheap alternative? We have to be ingenious. We have to be open-minded, and especially to optimize what we have at hand. And you know very well that necessity is the mother of all invention. So, but an important point is, don't forget that cheap resources are not just objects or devices. We can have idea which are the cheapest thing, optimization and organization of what we have at hand. So I will give you some example. You know very well the history of PCNL. The first nephroscopy was performed by cystoscope through a previous surgical nephrostomy tract. So what can we learn from history? Yes. So what can we learn from history? They had just an idea. This is the cheapest thing, no technology or special equipment. So they had the courage to use this idea. They had used the equipment in a different indication, so multi-use. They had maximized what they had available, and also they had shared this idea by publishing the article. So also by to plan for the procedure, as it was reported, 3D printing or plasticine biomodeling. But if you don't have this, we can do it. Cheapest thing is to do a mind visualization, intellectual 3D reconstruction. Yeah, like you enter your home and you know that the living room is in the right, the kitchen is in the left. And every time I tell my student and my friends to do this mind visualization. Another example, free of cost, is just to optimize. I had begun PCNL in 1997 in the prone position, and we had a real problem. I cannot do more than one PCNL a week. It took a lot of time, about 45 to 75 minutes. So back in 2003, I had the idea to use the split leg modified lateral position, which is derived from the lateral position, not supine, and the shoulder is in the lateral position. The pelvis is in an oblique position, and the lower limbs are opened. So without any cost, I had another idea that had opened all PCNL for us, and for most people in some private hospitals in Morocco. And you know, time is money, so we had also economic gain for we used just one set of drapes. Another idea that has pushed forward without any cost. So I had a problem in 1997 to extract the stones, especially in large stones like Staghorn calculi. So we had this idea to use the nephroscope as suction cannula. So the tube is adapted to the nephroscope operating channel, and it is used in the beginning of the procedure for suction of blood clots and pus, and to have a clear vision. Also, small fragments are extracted through the nephroscope operating channel. Larger ones are extracted through the amplas sheath. Also, in our experience, it is the best thing for matrix stones. So to develop PCNL, we have to do teaching and learning, especially on simulators. You know very well that virtual reality simulators are very expensive. It is very difficult for me in my city to have a poor kidney. So we had the idea to use a glove model. It is filled with saline and contrast media, and the tip of the glove is used as a calyx. However, this model is limited. We can use it only in the operating room, and we cannot do it in workshops or in meetings. So I was in a workshop in the University Hospital in Marrakesh, and they had this retro projector. So we can use it to do a projection of the shadow of the glove. Another time we didn't have this retro projector, and we thought of using the torch application of the smartphone. So the gloves are projected on a piece of paper, and we can use it to learn and teach puncture. And also we can shorten the glove. There are many ways, but these 3 or 4 models, they are just for to learn puncture in monoplan fluoroscopic puncture. That's what I use in my daily PCNL. So how we are oriented in the frontal and cranial caudal movement, but we don't know the depth. So how do we know the depth? So we move the needle from down to up in the blind fashion until the kidney is moved. So here in the glove, we are oriented toward the targeted calyx, but laterally what we do blindly is we move the needle from down to up until we see that there is a depression of the calyx, and we do the puncture. Also, we know how to do the puncture now with these models. So we have to learn how to do tract dilation. It was reported to learn this on a watermelon. It was winter, and it is difficult to have watermelon in winter in Morocco. So my wife was preparing couscous. This is our kitchen, and I see this small part of a pumpkin. So I thought, yes, this is a great idea, and I have trained on it. So we know to do how to do the puncture and dilation, but we have to train also on how to do the exploration and fragmentation of the stones. So we have this glove model with the numplat sheet into a glove filled with water, and we can learn all on the urology, flexible, rigid ureteroscopy, nephroscopy, fragmentation of the stone extraction. We have also an idea of homemade micro PCNL needle, and we can use laser. And it's very, very cheap and available in every room, operating room. So since 2004, I use only one-step dilation. And I think that for the people who are doing teaching or working in teaching hospital, it's better to use a safety guide wire. So how to do it free of cost? So one of the techniques is to use a segment of the coil housing the guide wire, or through the non-plus dilator, but we have to do 2 steps, and or outside and small fascial dilator, and it can do the trick. Otherwise, now we are using more and more this technique. It is like similar to the parallel axis sheet, ureteral axis sheet. So a slit is performed in an extremity of the ureteral catheter or WG pusher. And by pushing the dilator over the catheter, it dislodges the guide wire. So here in a patient, the guide wire is stored outside, and we do the dilation over only the catheter. Of course, it has to be a stiff catheter. And at the end of the procedure, we had used only one guide wire, and the guide wire is outside the implant sheath. Also, like I told you, in the history of PCNL, it's better to do one of the cheapest solution is to do equipment multi-use. So since 2004, I am doing mini PCNL with the rigid ureteroscope, but only as a second or third tract. So after puncture, progression in the retroperitoneum, and the stone is moved from the calyx to the renal pelvis, and it is extracted through the other tract. And when I met my friend Dr. Eskapal in Karachi, he had presented this technique, which is very good to use a drinking straw for mini PCNL. And also it is very good to use in obese patients since we can have a larger one, a longer one. So I was helping a friend to do a mini PCNL for stone in the lower calyx. And mostly we don't need any forceps or basket, but in this case we needed a basket and we didn't have one. We had only this perk encircle, which was 10 French, and the operating channel is just 6 French. So we dismantled this perk encircle, and we used only the inner insert, and the stone was moved from to be in the more accessible calyx. So I was in a workshop doing endopuloplasty, which is an endopulotomy transversal suture, but we had this bleeding, and this is the bleeding in the parenchymal tunnel. So we thought I would like to cauterize and to show the people that we can do it. So we didn't have an endoscope electrode. So we had used the membrane stylet of a ureteral catheter to do the coagulation. This is before, and this is after the coagulation at the end of the procedure. In another instance, the ureteral catheters that we had didn't have a membrane stylet. It was a plastic one. So what is the alternative? So we can use a basket, and the electrocautery is applied to a metallic part of the basket. So we were doing this Staghorn calculi. At the end of the procedure, we had this stone in the upper calyx. It was a little bit far from the nephroscope. We cannot dislodge it with suction or with the irrigation. We didn't have a nitinol basket. So what to do? We don't want to do another puncture. So we had this idea to use this floppy hydrophilic guide wire. We made it into a basket, and we had managed to move the stone and to extract it. Afterward, we had to push the idea forward. What can we use that is readily available in every operating room? So we can use a monofilament suture. Here is a nylon suture. It is waved into a basket and inserted into a coaxial WG pusher. We can move it and it is effective. So I was with a friend doing PCNL, and he had lost this light adapter, and we didn't have one, and we cannot take one from another endoscope. So what we do? What will you do? So we had this idea to use a small segment of a Foley catheter, and it fitted just fine. And we have done the whole procedure like this. And afterward, my friend didn't buy the adapter since he had this cheap alternative. So if you are doing PCNL and you have this large outflow, you don't have a spare rubber seal. So you can use the head of the syringe to take a small flap, or to use it wall in the nephroscope. And it is very effective. Also for the flexible, we have this large outflow and we don't have this fancy fibroscope seal, and it costs between $20 to $30 in Morocco. So what will you do? We have the injection port of serum bag, and it is very good. And also it is very tight. It controls the movement of the fiber of the basket. So how to adapt urethral catheter to a drainage bag? We can do it directly through at no cost, through the Foley catheter, or with this injection port of the serum bag. We can use also a valve of a Foley catheter at the end of PCNL. This is our idea of a homemade microscope PCNL needle with the 25 centimeter prostate biopsy needle. So George Bernard Shaw has said that progress is impossible without change. So we have to change our mind, and especially we have to be open-minded. And like I told you, it is very good to have this 3D intellectual 3D reconstruction and through a thorough analysis of the image. PCNL is rigorous. We have to do a rigorous technique. We are not playing. There are lives of patients. So all the technique, you have to be sure how to do it. And also we have to teach and learn in unstressful supervised environment, and for economic use of equipment. And we have to share and cultivate the idea. Like my friend Torpal has said, I had all these tricks on YouTube channel, and this is my my email, and I thank you.